This section is going to look at respiratory medications. What we're going to be doing is spending some time talking about the respiratory system and some of the physiology involved. One of the big focuses we're going to be talking about is going to be on asthma and the medications utilized to manage individuals who have asthma. And we're also going to be talking about different types of cough and cold medicines as well, and different types of medicines that people also use for seasonal respiratory allergies. So just an overview, we're going to look at the background on the pathology. We're going to look at the pathology of all the different things. Again, a lot of what we're going to focus on is going to be talking about asthma, but we're going to talk about allergies and colds as well and kind of how they get dealt with. We're going to look at classifications as far as how asthma gets classified based upon how often the individual has symptoms. We're going to look at the different types of treatments, various types of inhalers, different types of treatments to treat the inflammatory component of asthma will be very important. Talk about the different types of drugs and talk about the role, of course, as we would with the athletic trainer, looking at patient compliance with medications and managing their signs and symptoms. Looking at the respiratory system, just to kind of talk about some of the general functions and regions. You look at respiration and ventilation. There's a difference between these two. Respiration is actually the exchange of gases that takes place in the lower part of the respiratory system, whereas ventilation is the actual movement of air. So the movement of air that you take in, you breathe in and breathe out through the lungs, that's actually ventilation, whereas respiration is technically the actual exchange of gases that takes place. So when we look at the upper versus the lower airway, the upper portion of the respiratory system, the job of that is to essentially condition and filter the air that we breathe in. Okay, so what it does is it kind of adjusts the temperature and also humidifies the air along with filtering out different things, dust and things of that nature, so that in the lower airway it doesn't damage the lungs. And then obviously in the lower part of the airway is where the exchange of carbon dioxide and oxygen takes place, and that takes place at the alveoli at the end of the bronchioles. Now the bronchial tree is made up of smooth muscle. What that smooth muscle does is it allows for the constriction and dilation of the airways. We know that in individuals who are asthmatics, part of what happens with that bronchial tree is they get bronchospasm, so it constricts and it gets filled with mucus. So that's what kind of blocks their airway when that happens. In a healthy person, that smooth muscle can adjust and allow for constriction and dilation in response to what their body needs. So that's going to be some of the more important aspects of the respiratory system. So a lot of the medications that are going to be taking are going to affect different receptors in the respiratory tract. So in looking at this, understanding the autonomic nervous system, so the autonomic nervous system regulates things that we don't consciously or voluntarily activate. Now, how does it affect the respiratory system? Well, again, that smooth muscle that we talked about earlier, its job is to maintain that balance between bronchoconstriction and bronchodilation. And again, when you look at people with a lot of the respiratory conditions, particularly asthma, that's what gets affected. So that's what we look at kind of controlling with certain asthma medications. Now, looking at this, you have your cholinergic receptors, okay? And your cholinergic receptors are divided into what are called muscarinic and nicotinic. Medications that block the activities of those receptors are called anticholinergics. And they're usually what get utilized in, particularly with allergy and cold medications. And anticholinergics are going to cause things like decreased saliva, dry mouth, and gastric activity. Okay, so the cholinergic receptors increase the activity of the parasympathetic nervous system. Your adrenergic receptors, okay, are going to be your alpha and beta receptors. So you have alpha 1, alpha 2, and you have beta 1 and beta 2. So the alpha receptors are located in the peripheral blood vessels and will cause vasodilation. Alpha 2 receptors are involved a little bit in respiratory function. Okay, so we'll talk about some of that with the alpha 2 receptors. We don't get as much in detail with the alpha 1 receptors because they don't have as much of an impact in as far as respiratory problems. The beta receptors, particularly the beta 2 receptors, are going to be involved in respiratory function. So the division of the beta adrenergic receptors are based on their location and function. So the beta 1 receptors are located in the cardiac muscle. They increase the rate and strength of heart contraction. The beta 2 receptors are located in smooth muscle in the respiratory tract. So we're going to be primarily looking, as far as from a respiratory function, to look at the beta 2 receptors. So that's what a lot of our the medications that we look to deal with are going to involve the beta 2 receptors. Another important thing to look at in the respiratory system, and we'll talk about this particularly with both asthma and allergies, is histamine. Okay, histamine is involved in regulating inflammation. Now, there's different types of histamine receptors in the body. There's you have H1 receptors, H2 and H3. Really, we're only looking at H1 and H2 being targeted by drug types. Okay, H1 receptors are found on smooth muscle and nerve endings, and these are the receptors that will cause allergic reactions and will also cause bronchoconstriction. The H2 receptors are located in the gastrointestinal tract, and they regulate stomach acid. So we'll talk about that when we get into the gastrointestinal medications. So we're primarily focused right now on the H1 receptors, as they'll be more involved in bronchoconstriction and the different signs and symptoms you get. So if you think about the signs and symptoms that you get with allergies, you get runny nose, you get nasal congestion, that sort of thing. That comes from your H1 receptors. Now, looking at asthma and give kind of an overview of the pathology. First of all, you're looking at potentially three different things. You could have asthma, you could have exercise-induced asthma, you could have exercise-induced bronchospasm. The differences between them are this. Asthma involves both bronchoconstriction and inflammation. So there's actually an inflammatory process that goes on in addition to the bronchospasm. Exercise-induced asthma is when the asthma is it has a trigger being exercised. So the exercise will bring about the bronchoconstriction and the inflammatory response. Exercise-induced bronchospasm does not involve an inflammatory response. It only involves the bronchoconstriction. So that's the difference between them. So I'm looking at asthma. We have the inflammation and bronchoconstriction, and I have some of the triggers listed here. One of the triggers being NSAIDs, and we talked about this. Again, if you go back to the anti-inflammatory chapter and you look at that chart, I talked about this a little bit within that, how when you get some individuals who are sensitive to taking NSAIDs, and it allows that leukotriene mediated response to kind of overtake them and become to kind of trigger the asthma attack. Other things, again, colds, viral infections, gastroesophageal reflux can produce this. So there's various triggers. Not everybody's as sensitive to certain triggers as others. So those are some different things that kind of either trigger asthma and some of the different types of asthma that an individual can have. So this is just a picture illustration kind of showing you what goes on. So if you look at the normal bronchiole, you can see, if you look at the asthmatic bronchiole, you can see the swelling and inflammation that occurs and the increased mucus production. So it kind of just closes off the airway a little bit. And the big issue with people that have asthma attacks is that they get air trapped in their lungs. It's not so much a breathing in issue, it's a breathing out issue. So they kind of get air trapped in their lungs. They're not allowed to breathe out, and that's what causes a lot of the issues that they're faced with. So just some of the signs and symptoms: shortness of breath, wheezing, coughing, headache, stomach cramps, pain, tightness in the chest, nausea. And usually when you look at activity, Symptoms will usually start about 6 minutes into activity, and for a maximum 15 minutes post. So that's usually when you'll start to see symptoms develop as it relates to activity. One of the tools that can be used to kind of monitor an asthma patient and see how they're doing is through a peak flow meter. And what this does is it measures peak expiratory flow. And usually what you'll be doing with this is that an individual will base their treatment and participation in athletics on a personal best. So what they'll do is when their asthma is very well controlled, they'll get a personal best, and then depending upon where they're at, it's always a good idea prior to activity that a person does one of these tests just to kind of see how they're doing that day. Based on the personal best, it'll kind of dictate how the person should handle their asthma during that day, whether they should take a puff of their, take 2 puffs of their rescue inhaler, or even for that matter, if they're not having a good day, if they should even participate in practice. So this should be something that most patients, or I would probably even argue all of them, should probably do prior to activity if they're involved in athletics. These are your different classifications of asthma, and it's important to kind of see, particularly if you have individuals who are poorly controlled, to kind of do this. Table 7.1 in your textbook also has this this classification in there. They have some of the characteristics. They don't get so much into the lung function. I kind of have that up there for your reference. So kind of take a look at this table, and also you could look at table 7.1 in your textbook on page 95. Kind of break down the classifications and kind of how how often they're having symptoms, what their lung and what their lung function is. And again, this could, by being aware of this, with your asthma patient, you could kind of then possibly communicate with the physician if it seems like they're having more frequent attacks, because maybe a change in their regimen may be necessary. As far as treatment goals with the condition, ideally you want to treat both aspects. If you're looking at asthma, exercise-induced asthma, treat both the inflammation and the bronchoconstriction. The idea is you want as near normal function as possible, because you don't want to create a situation where you're producing chronic symptoms to potentially cause gradual progression of the issue and have the person have issues as they get older. So you want to make sure that, again, their asthma is well controlled, they're not having frequent attacks, avoid triggers if possible, and the appropriate use of medications. Make sure they're not, sometimes particularly in athletics, athletes have a tendency to kind of overuse the rescue inhaler. If an athlete is having to use their rescue inhaler an excessive amount, that means that something else needs to be controlled for. So those are different things to keep in mind. Now, in referencing drugs for asthma control, there's 2 basic types. You have your bronchodilators, and you have both short and long-term bronchodilators. And you have anti-inflammatory medications. So again, we have to control for those 2 different aspects of asthma. Okay, if you're dealing with somebody that has exercise-induced bronchospasm where there's no marked inflammation present, then you could take that into consideration. The physician will definitely take that into consideration in their treatment. So we're going to look at, and again, I want you to keep both these questions in mind as you're listening to the rest of this and also reading in your textbook. But what are the basic function of these 2 different types of drugs, and what are the roles of the different categories? So we have different types of medications that are involved in the anti-inflammatory treatment of asthma, and we also have different types of bronchodilators. Your beta-2 agonists are going to be some of your bronchodilators. So remember, we talked about the receptors. Beta-2 are in the lungs, beta-1 are in the heart. So the advantage you get with a beta-2 agonist is you get decreased cardiac effects because they do not affect the receptors in the heart quite as readily. You have both short-term and long-acting ones, and we'll talk about some of the differences with those. They're going to be delivered via a meter-dosed inhaler, and we have a picture of that on there. The mistake a lot of individuals make is that they don't use a spacer. Again, this medication has to reach the lungs. Okay, so the mistake a lot of people make is they don't use a spacer. They utilize the medication, and basically it just kind of all goes in their mouth, and they don't get as much to their lungs, so it's not as effective. Your short-acting rescue inhalers, and again, I would refer you to also look in your textbook. Table 7.2 illustrates your different types of rescue inhalers. So you have your short-acting, your albuterol is an example. Preventol and Ventolin are also short-acting. These are you could use these also prophylactically. So some people will use an albuterol inhaler in order to prevent possibly having an asthma attack. So they can be used in the situation where an individual is starting to feel that they're having an asthma attack, or as well, a lot of people prior to activity will utilize the rescue inhaler as a means in prevention. Now your long-acting beta-2 agonists, so they're effective for up to 12 hours. Salmeterol or Ceravent is an example of a long-acting beta-2 agonist. A lot of times these will be added to an inhaled steroid. We're going to talk about the role of steroids in treating asthma, and the other advantage you get with the long-acting is they can help with nighttime symptoms. Some individuals with asthma will suffer from significant nighttime symptoms, and the long-acting beta-2 agonists can assist with this. Talk a little bit about what a nebulizer is. Some of you may have heard of nebulizers, but what nebulizers do is they aerosolize the medication. So what the individual could do, and you see asthmatics, it's not solely just used in individuals that have asthma. People with chronic bronchitis will sometimes use these in other respiratory issues, but in situations where an individual is suffering from a real bad exacerbation of asthma, what this does is it delivers the medication over a time span of several minutes. So the individual can basically sit and puff the nebulizer, and what that do is will deliver a very high dose over a long period of time to assist with symptoms. Another way that medication can be delivered for asthma patients are through the use of breath-activated inhalers. These usually will be used to deliver a lot of the inhaled steroids that can be delivered. There's other types of medication that we're going to talk about in a little bit that are delivered this way as well. So the breath-activated inhaler, what this basically is you can kind of see the picture on the side shows how they work. So the person will take a breath out after they set up the unit, and they'll inhale the medication. They'll hold their breath, and that will deliver a dosage of the medication. Anticholinergic bronchodilators, they're less effective than beta-2 for asthmatic patients. The mechanism by which they work, they do work to reduce airway constriction, and they do that by blocking acetylcholine activation on the receptors. So they basically attach to receptors on the parasympathetic nervous system, which creates one of the adverse effects of sedation. That's one of the main adverse effects associated with these. More commonly, where you see these being utilized is in chronic obstructive pulmonary disorders and in chronic bronchitis. You don't see these prescribed a lot of times, particularly by themselves with asthma patients. So they sometimes can be used as an adjunct with other asthma treatments, but they will not be a frontline source for reducing bronchoconstriction. Now, in some instances, an individual may have to go on systemic corticosteroids. Usually this will be during a time when an asthma patient is having a lot of reoccurrences of asthma attacks, a lot of severe acute attacks, and this will be used to help inhibit the inflammation. They'll use this in conjunction with their beta 2 rescue inhalers. Again, as far as adverse effects, I'm going to refer you back to what we talked about when we were discussing oral corticosteroids. The important thing here, as with any instance where an oral corticosteroid has to be taken, is that you have to, one, limit the course to as short amount of time as possible, and you always have a taper. Okay, so in other words, when the person, they don't just stop taking the dosage of the medication, they'll actually be weaned off of it. Depending upon what their treatment dosages will dictate how they go through their taper. So it's not like a lot of other medications where when you're done with the course, you're done with it. Take, for instance, an antibiotic. Say you're on an antibiotic for 14 days. After 14 days, you're just done with the antibiotic. With corticosteroids, remember, you have to taper. Okay, and the reason for that is sometimes your body will not produce the corticosteroids that your body makes naturally as much. So you want to make sure that your body gets used to having to produce that it doesn't, so the person doesn't get really sick from just stopping the corticosteroids. And it's important that the patient is very aware that they can't just stop taking them. Now, the inhaled corticosteroids, you could use these for more long-term therapy. It could help in decreasing the frequency and severity of the attacks, and it could help increase the response of the beta 2 agonist drugs and those bronchodilators. So you can use daily for up to 3 months. Will start to produce the maximum effect. The advantage to an inhaled corticosteroid is that you get little to no systemic effects, as far as, particularly as related to the side effects. One of the biggest problems you could possibly run into are mouth and throat problems, particularly thrush, which is an infection in the mouth. So that's the more common side effect you would have with this, because it's more of a local effect because of the means in which the medication gets delivered. Now, some other medications that can be utilized to reduce the inflammatory response associated with asthma. You have your mast cell stabilizers. So mast cells are the cells responsible for producing histamine, which will be produced during the inflammatory response. These reduce inflammation, but they are not steroid drugs. Okay, so they're non-steroidal. They're used to prevent the release of histamine, and they help with long-term therapy. Cromolyn sodium is one of the more common mast cell stabilizers. These are available as a meter-dosed inhaler administration. So again, these are strictly for reducing the histamine response. That will bring down inflammation, but they are non-steroidal. Leukotriene modifiers, again, if you go back to that chart on inflammation that we talked about earlier on in the semester, leukotriene modifiers, and some of them are listed on here, Accolate and Singulair are very common leukotriene modifiers. They affect the leukotriene activity, so if you go to that part of the chart, or the flow chart, if you will, on inflammation, you can see where the role here plays. Again, this is for more long-term therapy and more preventative purposes. So this is not something that, again, would be utilized if a person was having an acute exacerbation or an acute asthma attack. This would be something that, if found beneficial for the person, they could use it long-term to help prevent asthma attacks from occurring. So exercise-induced asthma, and we're going to talk a little bit about how and why this occurs. And exercise-induced bronchospasm essentially have the same things at play, with just the exception of you don't have the inflammatory response that comes about with asthma. So the exercise-induced asthma, you look at, there's two different theories that basically for the most part still produce the same response. So the water loss theory is this. In the water loss theory, the person that has exercise-induced asthma, from breathing in, the airway kind of dries out as it's trying to humidify the air, And what happens in individuals that have this is from the water loss, so all the humidity loss to trying to humidify the air, there ends up being a rebound congestion of the circulation, meaning that you get this massive increase in circulation to the airway, and that produces the constriction effect. The heat exchange theory is basically the same thing, with just the exception it involves temperature exchange versus an exchange in water. So, one of the things that you have to understand with asthma is typically triggered, and in people with this much even more, by cold, dry air. Okay, cold, dry air is a trigger for asthma. So in the heat exchange theory, if we're looking at somebody with an exercise-induced asthma or exercise-induced bronchospasm, what's going to happen is they're breathing in cold air, and particularly mouth breathing will make this worse. But as the cold air is going into the airway, again, the airway has to warm the air before it gets into the lungs. Same thing happens. You end up getting a cooling of the airway. You end up getting, again, that rebound circulatory effect, where now the airway more or less gets engorged with blood, and it produces that vasoconstriction. Interestingly enough, with exercise-induced asthma and exercise-induced bronchospasm, there's what's known as a refractory period, meaning this, and this can be used in the prevention of an attack, where a person with exercise-induced asthma through a warm-up can actually induce mild symptoms, and then once they do, they can take their inhaler. And by doing this, what they do is, since they technically gave themselves a mild asthma attack, they can't have another asthma attack for a certain period of time. So certain times, if people find that they can do this, they will do this prior to a contest or prior to activity. They'll go through the warm-up, induce mild symptoms, take their inhaler, and then they won't have to worry about having an asthma attack while they're participating in activity. Again, if someone's going to try and do this, it's a good idea that they experiment with it on practice days. Another thing that will help in individuals who have exercise-induced asthma or exercise-induced bronchospasm is appropriate off-season training, conditioning themselves, so that this doesn't become an issue. And sometimes they will also use a long-term beta-2 agonist as well. So again, depending upon how the person could kind of treat this, they may use that preventative technique that I just described. Some of your adverse effects of some of these medications, your beta-2 agonist, nervousness, restlessness, there could be potential throat irritation, and it could also cause airway hypersensitivity. The inhaled steroids, we talked a little bit about the formation of thrush. You could also get throat irritation and hoarseness associated with that as well. Ideally for the beta-2 agonists, again, it's good to encourage people, albeit they never use them, but spacers can be very beneficial, because the spacer can certainly allow the medication to get into the lungs, and instead of it just kind of coating the inside of the mouth. So your oral steroids, we talked about those at length at the beginning of the semester. I would just suggest you maybe review some of that information instead of covering it here again. The inhaled non-steroids, taste, throat irritation, and dry mouth are some of the common things. And the oral non-steroids, dry mouth, sore throat, headache, and rash are some of the issues associated with them. With the regulations as far as what's allowed, it's important to know what type of documentation that your athletes need to have and what testing they have done in order to make sure so they don't end up having a positive drug test and end up having a situation where they get suspended or having some type of issue occur. So with the NCAA, if they have a beta-2 agonist, they need to make sure that they have a prescription for that. If they have a prescription for the beta-2 agonist, that would cover that. There's no corticosteroid restrictions. The World Anti-Doping Agency, if a person has exercise-induced asthma or exercise-induced bronchospasm, there needs to be specific diagnostic testing done for that and have it documented. And there's only certain beta-2 agonists and inhaled corticosteroids that the person could take. There are some therapeutic exemptions, but so obviously if you're in a situation where you're dealing with, an Olympic athlete, if they have asthma, you need to make sure you have the appropriate documentation because the restrictions there are a little bit more than what the NCAA has, so it's important that you're aware of that. With the athletic trainer's role, just to kind of bring out some important points with that. Again, monitor symptoms. If a person's having repeat asthma attacks, it's important to kind of sit down with them, talk to their physician, and just kind of see if maybe some change in their regimen has to take place, or what are some other things that can be done, because a person shouldn't be having constant asthma attacks. Clinically, I've dealt with some difficult asthma cases, so it's important to really communicate with the physician with that. Educate athletes on proper use. They shouldn't be overusing a rescue inhaler when they're doing it. So if a person's having to use their rescue inhaler a lot, then again, we need to probably manage their symptoms a little bit different. Be aware of their adverse effects. Make sure that you should have health histories on all your athletes, and in an ideal case, have a spare rescue inhaler. It would be a good idea if you're working with one particular sports team to have a spare rescue inhaler for everybody that that has been diagnosed with asthma. And then be aware of other potential issues with other medications, particularly NSAIDs. Again, we had discussed how certain individuals can be sensitive to NSAIDs and how that could possibly spark asthma attacks. And one of the reasons why I bring up NSAIDs is just because they're commonly used over-the-counter drug by athletes. So make sure that if a person seems like they're starting to have issues because of that, that you kind of deal with that appropriately. Looking at allergy and cold medications, so we're going to talk here about different types of medications. A lot of these are sold over the counter. So with allergies, we know that we have a lot of them are produced by environmental stimuli, and what allergies involve is an overproduction of histamine. So we have a little picture on the side there kind of showing how an individual will produce histamine in response to some sort of trigger, and the trigger in the picture is ragweed. So you can kind of look and follow that. You see the ragweed coming in contact with the cell in the body, and the cell ends up making a large amounts of the antibody to the ragweed, and those antibodies end up attaching to mast cells. And then when a person comes in contact with ragweed again, that mast cell will end up producing large amounts of histamine, which will cause all your typical symptoms of watery eyes, itching, running nose, what have you. So that's basically how an allergy kind of gets started. And when you look at colds are typically caused by viral infections. So again, if they're viral infections, antibiotics will not be effective in treating colds. So if you have cold symptoms, don't go on an antibiotic because you'll be taking the antibiotic unnecessarily. So your antihistamines, there's 3 general effects to antihistamines. They produce alteration of histamine action, they produce sedation, and they also produce anticholinergic activity. So decreased saliva, dry mouth, and constipation are some of the anticholinergic activities that they will produce. Now with colds and allergies, their symptoms could be very similar, so sometimes it can be a little hard to tell if somebody actually has a cold or an allergy. Typically, allergies will produce more of the itchy nose and eyes, more sneezing, watery eyes, runny nose, whereas colds a lot of times will have more of the coughing, the sore throat. Certainly with an allergy, you can potentially still maybe get a dry, scratchy throat, particularly if you maybe have some post-nasal drip from the allergy. So that's where I say, like, you have your typical symptoms and you have some things that could sort of cross over, but that's classically a lot of times what you see when you look at symptoms of allergies versus symptoms of colds. Plus, the other thing, too, to take into consideration is the time of the year. So if you look at somebody, maybe during the the springtime, starting with the itchy nose and watery eyes and the sneezing, you could be looking there at more allergy symptoms. Or certain times of the year, certain areas where you live, it may produce allergies, so that's something to take into consideration as well. So the antihistamines that you buy are typically used for allergies. Some individuals will use antihistamines for cold symptoms, and we'll talk about what could be beneficial about that. When you look at antihistamines, you have first generation and second generation antihistamines. So they're antagonists to histamine receptors. Your first generation antihistamines have a much shorter duration of action and typically will produce sedation. The most common one that people hear about or are aware of is Benadryl. Benadryl is a first generation antihistamine, and it's noted for causing sedation and causing drowsiness. Whereas your second generation antihistamines, they're actually no more effective per se, but they last a lot longer and they don't produce that drowsiness. So, and all of these now can be bought over the counter. You have Claritin, Allegra, Zyrtec are some of the more common ones. Again, they're not any more effective per se than the first generation. They just don't produce the drowsiness and they last longer. For instance, you could take a Claritin, Claritin can be 24-hour. You could literally take one Claritin a day to control your symptoms. So your antihistamines, we talked a little bit about how they work, but we'll mention some other points here. So they decrease vascular permeability, so a lot of that congestion and everything that the people will get will be caused by increased permeability of the vasculature. They decrease smooth muscle constriction, so they'll kind of open up the airways a little bit. The first generation, as I discussed, have a sedative effect. They also have a much shorter duration of action. Typically you do look at much shorter duration of action with a first generation. And again, here on the picture, again, just kind of showing the mast cell releasing histamine after being exposed to the allergen. In a situation where the antihistamine has been taken, it will block it from causing the histamine not allowed to attach to the blood vessel wall and cause that increased permeability. The adverse effects of antihistamines, and what I want you to kind of make note of on your own, is just to kind of look at the mechanisms by which these occur, and this we've kind of already talked about. So the anticholinergic adverse effects, dry mouth, constipation, mucous membrane dryness. You also have cardiac stimulation, blurred vision, urinary retention, and we mentioned many times the sedation involved with first generation antihistamines. A lot of times people will take both an antihistamine and a decongestant because an antihistamine by itself won't decrease nasal blockage, whereas a decongestant will. And a lot of your common antihistamines are also sold with a version with a decongestant right in them, and that's what the D stands for. If you go to a store and you see Claritin D or Allegra D, that means that it has a decongestant combined with it. As far as using antihistamines with a cold infection, some people do take antihistamines when they have colds, and it can be effective basically because of the drying effect. So it may help with some of that, but there's questionable efficacy whether an antihistamine. There probably are better options when an individual does have a cold. Individuals with allergic rhinitis could also be prescribed steroid nasal sprays. They're very effective for this. They can help decrease nasal congestion and also just the runny nose symptoms associated with this. The advantage you get with the steroid nasal sprays, very similar to the inhaled corticosteroids for asthma. There's no adverse systemic effects associated with them. Most of the adverse effects you're going to get are going to be local effects. So like nasal irritation and nosebleeds are some of the common adverse effects you would see with these. You want to make sure that when you're spraying these, you direct the flow away from the nasal septum. And one of the more common steroid nasal sprays is what's known as Flonase. or fluticasone is the generic name. Your cough and cold medications, there's various types. You have decongestants, you have antihistamines, which can be used, again, we talked about how they can be used for colds, expectorants and antitussives. And you also have various types of combination drugs. For instance, NyQuil is a combination drug. So it has a couple different drugs in it to treat different types of symptoms. However, if you want to just focus on one particular symptom, for instance, if congestion is your main problem, you have some sinus congestion, you can just take a decongestant instead of taking all the other medications with that. So individuals with congestion, and these can be used in individuals that have both sinus and ear pain and pressure from congestion in those regions. They're alpha-1 agonists, so they work on the blood vessels in the nasal mucosa and they cause vasoconstriction. So there's different ways to administer decongestants. You have your spray forms, which you'll see in Afrin, and you have your oral decongestants in Sudafed. So I would like you to look up the generic names for those and kind of on your note sheets just make a note of what they are, but those are your two basic forms, either the spray or the oral forms. Your adverse effects associated with these, you have headache, nausea, dry mouth and nose, dizziness and nervousness. And with the sprays, you have rebound congestion. So it's very important. One of the things to note, if you've ever used Afrin before, they work. The sprays work really well. Afrin will really open up your sinus passages. The thing about Afrin is you could only use it for a maximum of 3 days. If you use it beyond that time frame, you run the risk of getting rebound congestion. What that means is instead of actually opening up the nasal passageway, you'll produce where your congestion gets worse than what it was before. And some people actually end up getting addicted to the nasal sprays to just keep their nose open all the time. So it's important to limit the time frame that you're using. If you're going to use a spray like an Afrin, that you limit how long you use it for. Expectorants are drugs that produce mucus clearance. So what they do is they kind of loosen up the mucus, and what the individual will do is they'll have a productive cough. So what a productive cough basically means is as the person coughs, they cough up the mucus. And the expectorants kind of encourage that. The most common expectorant you'll see is what's called guiafencin. So you'll see that. So if you see that ingredient in a cold medication, you know that the medication has an expectorant in it. Many of your decongestants have both an expectorant and a drying decongestant, kind of as a combination. It's not unusual to see that. You'll see pseudoephedrine and guiafencin in some of your decongestant medications. It just means it is a combination of the two. Antitussives are utilized to suppress cough, and antitussives will either suppress the cough via a central mechanism or a local mechanism. So some of your antitussives, again, you look at cold medications, you could see whether or not they have these in them or not. Dextromethorphan is a common antitussive. Sometimes your antitussive cough medications will also add a narcotic to them, codeine or hydrocodone. Tessalon is a local effect antitussive, and these are in oral form, so these usually come in pill form. And what these do is they have a local anesthetic effect on the epithelium. These are only available via prescription. So your dextromethorphan is a antitussive that's available over the counter, and again, that will have more of a central effect as far as suppressing cough, whereas a Tessalon will have more of a local effect. And again, it produces an anesthetic effect on the epithelium that will be available solely by prescription. And these are just some of your common adverse effects associated with expectorants and antitussives. So mild dizziness, drowsiness, nausea, and stomach cramps are possible adverse effects associated with them. So just some things to reflect on, and the two questions on here I'm actually going to pose on the discussion board, and I'm going to have you answer those. So, obviously understand an individual's asthma regimen, so again, it'll be important for any group of athletes you work with. Make sure you know who is an asthmatic and understand what their treatment regimen is. And again, anytime you have any questions or issues pop up, you could certainly communicate with your team physician and or even their physician that's kind of overseeing their treatment. The two questions I'm going to pose on the discussion board: why it is important to educate athletes on cough cold medications, and what are potential issues with cough and cold medications. So some of that's described in your book. I want you to kind of look at this. So this is besides the side effects. What are some things that you would want to discuss with athletes in regards to these medications? And these are your learning outcomes for this section. So again, make sure for those just general thought points, make sure you kind of make some notes for yourselves on the handouts if you print them out, which again I suggest, or make some notes in your notebook. And again, make sure you answer those two questions on the discussion board page on Blackboard.